Hello, and welcome to Biomechanics of Spine Stabilization, Self-Assessment and Review. This will be a review of Chapter 12, Spine Fusion, presented by Gabrielle Santangelo, Thomas Peters, and Daniel Schuba. In this video, we'll discuss some of the important concepts from Chapter 12, including ventral interbody grafts, dorsal bone grafts, placement and anatomic consideration for grafting, and the load forces after implant placement. Stabilization procedures are typically performed after decompression, as seen from panels A to B. This serves two purposes: to reduce the ventral mass impinging on the spinal cord and to provide space prior to placement of a dorsal instrumentation device. Spinal alignment can be restored with a loosening of the spinal elements using discectomy or corpectomy. After this is completed, dorsal instrumentation can be placed as seen in panel C. Finally, as seen in panel D, the ventral graft is placed. We will discuss specific considerations about graft placement shortly. If spinal distraction is required, the bone graft needs to be placed after the dorsal instrumentation to avoid loosening the graft. An exception is the situation in which it is mandatory to place the bone graft before the instrumentation construct is secured. As seen in panels E and F, the dynamics of spinal reconstruction may be enhanced by the intraoperative application of bone healing enhancing forces. In this situation, the decompression may be accomplished first. Then, the pathologic segments may be distracted by the implant and the bone graft inserted. Finally, the construct may be compressed onto the bone graft. This allows load sharing between the ventral interbody bony structures and the dorsal instrumentation construct. Factors that should be considered when selecting a bone graft for fusion including matching the integrity of the bone graft bed to the graft, the cross-sectional area of the graft to the vertebral body, and where the graft is situated on the end plate. These three images depict the importance of matching the bone graft bed to the bone graft for ventral interbodies. If the bone graft is denser than the vertebral body, the graft can knife through the vertebral body, as seen in panel B. However, if the bone graft is weaker than the vertebral body, the graft can fail, as seen in the final image in this series. The density, integrity, and modulus of elasticity should be similar to that of the vertebral body. It should neither be the weakest nor the strongest link in the stability linkage system. The extent of penetration of an interbody strut is inversely proportional to its cross-sectional area of contact with the vertebral body end plate. Note that the thinner, less substantial strut in A has pistoned further than the more substantial strut. In B, a mortise that is poorly fitted to the bone graft increases the chance that a space will persist between the bone graft and the mortise, as seen by the shaded area in C, or that pistoning will occur, as seen in D. The neutral axis of the spine, represented by the shaded area in the left-sided figure on the screen, is the region where normal weight bearing may be expected to cause minimal distraction or compression. Therefore, interbody bone grafts should be optimally placed within or slightly ventral to this region, particularly if dorsal stability is not adequate. If dorsal stability is adequate, a more ventral location may be optimal, as seen on the right. This allows sharing of the axial load between the ventral strut and the intact dorsal spinal elements. Finally, the vertebral body itself may be used to support applied axial loads when ventral interbody bone grafts are used. If the medullary bone of the bone graft is too weak to resist the applied axial loads, the graft itself may be placed on or near the end plates of the vertebral body as depicted. The end plate provides a resistance to spinal column collapse that the soft medullary bone of the vertebral body cannot. Now we'll discuss fusion healing and the forces exposed to a construct after surgery. In these figures, IAR indicates the instantaneous axis of rotation, and short and long moment arms are represented by D1 and D2 respectively. Acutely, a dorsal bone graft does not resist axial loads well. Panel B shows that flexion causes distraction of all points dorsal to the instantaneous axis of rotation. This causes a dorsal bone graft to be exposed to bone healing inhibiting forces, as shown by the arrows. On maturation of dorsal fusion, the graft itself can resist significant flexion deformation if adequate axial load resisting abilities are present. This is accomplished by application of a flexion-resistant moment arm. The longer the moment arm, the greater the ability to prevent flexion deformation. An interbody bone graft and its acceptance sites should be fashioned with the intent of acquiring specific desired effects. Unless a ventral interbody bone graft and its acceptance site are conformed with the intent of acquiring specific desired effects, the only stresses resisted by a bone graft are axial, as seen in panel A. In this case, the bone graft functions only in a distraction or axial load resistance mode. If a deep mortise is created within the vertebral body, as seen in panel B, this can provide a translation-resistant component, though not particularly strong. This is a terminal three-point bending construct to resist translation. Notably, however, panel C demonstrates that as a standalone implant, ventral interbody struts resist translation poorly. Finally, we'll discuss how changes in body position alter the load borne by an implant. The concepts of load bearing and load sharing should be considered whenever a spinal implant is used. To illustrate this, we'll use a thoracolumbar fracture treated with short segment pedicle screw fixation with or without an interbody fusion as an example. If this fracture is treated with an implant that is placed in a neutral mode, as seen on the left of panel A, and an upright posture is assumed, as seen on the right, the axial load applied to the implant is approximately equal to the weight of the torso positioned above the implant. In this case, the entire load is transferred through the implant. Because the total load passes through the implant, the fractured vertebral body is protected from axial stresses. However, if this implant were to be placed in distraction mode, as seen in panel B, left and depicted by the short arrows, the implant would be loaded in distraction, thus resisting compression. When an upright posture is assumed, the implant bears an additional load, surgical load plus the load associated with the weight of the torso above the implant. The load borne by the injured vertebral body is negligible. Finally, if the implant were placed in compression, as seen by the short arrows in panel C on the left, after the placement of an interbody fusion, assumption of the upright posture would result in the implant bearing an axial load less than the weight of the torso positioned above the implant. The implant thus shares the load with the intervertebral strut, which is loaded in compression. In fact, if the negative surgical load is equal to the weight of the torso positioned above the implant, the load borne by the implant during the assumption of an upright posture is zero. That is, the surgical load is equal and opposite in direction to the weight of the torso positioned above the implant. They thus may cancel each other out. The pedicle screw implant is therefore unloaded. However, the bone graft is indeed loaded.